So without any further ado, some of these other images here, more space. Okay, we're going to talk today about panniculitis, and some of this will be a little bit of a review because there's some panniculitis that's associated with vasculitis, and so we talked a little bit about a couple of these last week when we talked about vasculitis. For those of you who were here last week, a little bit of it will be a review, but it's never a bad idea if you've got a disease that affects two different sort of organs to kind of know the way that they affect each one slightly differently. So again, basically in order to get a diagnosis of this, you've got to get into the fat. So you got to take a not large enough biopsy. We get a fair number of people that like to do punches and things like that. And, you know, if they get down deep enough, it's great, but a lot of times they just don't. And a lot of times the fat is degenerated. So when you do your punch and you bring it out, well, the fat that's damaged and sort of degenerated down there stays at the bottom of your punch. And then all you're looking at is some dermis and some overlying epidermis. And unfortunately, you don't get a diagnosis. So sadly enough, in a lot of these cases, although nobody likes to do this, you may have to do an incisional biopsy and set the patient up for that. So anyway, we're going to go through the general principles of this. And you know, most of these tend to be on the legs, but sometimes there are lesions elsewhere in the body, and we'll talk about some of those. There's variable surface change. Sometimes they can ulcerate. Sometimes there's basically nothing of the overlying epidermis. Sometimes their lesions are painful. Sometimes they're not painful at all. And when you look at the main patterns under the microscope, we like to divide these into whether the septa are mostly involved or the lobules are mostly involved. Now, in the real world, I've got on here septal mostly and septal and lobular mostly. That's really more correct. It's relatively rare that these entities just purely hit the septa or purely hit the lobules. There's usually a little bit of an overlap between the two, but the diseases do tend to affect one of the two predominantly for the most part. So that's helpful, and that's what you should do when you look at these under the microscope. Ask yourself first whether it's septal mostly or if it's lobular mostly. And then the second thing you want to ask yourself is whether there's vasculitis or not. And like we talked about last week, you can get relatively larger blood vessels involved sometimes when they're migrating through the subcutaneous fat. So ask yourself whether there's vasculitis or not. If there's not vasculitis, that tends to put you in one category. If there is vasculitis, it puts you into another category. And then these are the mostly lobular ones. Probably the majority of the biopsies that we get are the septal panniculitis. By far the most common that we see is Erythema Nodosum, or possibly just panniculitis due to a rupture of a cyst. But these are the lobular ones. We're going to kind of go through and talk about most of these today and give you some examples. And then some of the ones that are the mixed patterns. So when it's really, you're not able to really classify it as mostly one or the other, you should think that it may be related to something outside in, like cold, factitial, maybe an infectious disease that's causing panniculitis. So if it really doesn't tend to give you any pattern at all, then just pull back and say, you know, this doesn't make any sense. Maybe it's not really a true primary process. So let's start off looking at the septal panniculitis without vasculitis. And these are the three most common that we see. By far the most common is Erythema Nodosum. So basically most of these are usually relatively young individuals. Women tend to be more commonly affected than men. They have a prodrome, fever, chills, malaise, arthralgias, things of that nature. And these are usually tender. They're almost always on the anterior shin. They usually heal up in about 3 to 6 weeks, but there is a form of chronic Erythema Nodosum. The old name for that, Villanova's disease, and that can be a form of Erythema Nodosum that can go on for months or years. So just remember that, something that can be seen in some cases. If you look under the microscope, it tends to give a panniculitis that's mostly septal with granulomatous inflammation. Now, if you get it early, you may not see very many histiocytes. You may see some edema, some hemorrhage, some neutrophils, even some eosinophils sometimes. Later on, you'll see the classic granulomatous inflammation involving the septa. So here's the markedly thickened septum, and then these are the multinucleated histiocytes surrounding it. And this is what's known as a so-called Meeschers radial granuloma. Now, again, I'm not a big fan of using a lot of these older acronymic names and things like that that tend to go along with these. So I don't think the board's going to ask you that. But the most important thing is just to realize you get granulomatous septal panniculitis in Erythema Nodosum. And here's a beautiful biopsy. This disease, you should be able to kind of suspect it at low power. You can see right away that the septa are markedly thickened. They should be just a tiny little thin rim of strand of collagen here almost, and this is probably 100 times thicker than it should be. And then you see the periseptal and septal inflammation here. And as you go to higher magnification, it's an admixed infiltrate. There's some histiocytes here. There's some neutrophils. So it's got this granulomatous, mostly septal panniculitis. There's a multinucleated giant cell right there. So again, this doesn't give you that classic so-called Meester's granuloma appearance. Again, I don't think you really need to focus on that. Just remember that it's mostly septal, mostly involving a little bit of the lobules at the periseptal area here with granulomatous inflammation. So again, nice example of Erythema Nodosum. And this does not have a vasculitis with it. So it's a non-vasculitic septal mostly panniculitis. Now, scleroderma, morphia, any of the disease, we talked about this in the lecture we talked about on connective tissue disease recently, and basically you can get the same changes that go on in the dermis down in the subcutaneous fat. And again, this hits the septa primarily, leaves the lobules alone, but gradually the septa gets so thick and large and sclerotic that it chokes it out. And basically you're left just mostly with thick sclerotic collagen where the fat used to be. And there's several different forms of this when you're dealing with scleroderma panniculitis. You get subcutaneous morphia, you can get so-called morphia profunda, which is probably a synonym. And then eosinophilic fasciitis, we'll talk about that. That's where you really need to get a very, very deep incisional biopsy down into the fascia, or you won't see evidence of the involvement because it's really, really deep to the skin. And if you look at this under the microscope, it shows mostly septal panniculitis, no vasculitis with sclerosis of the septa, thickening of the collagen bundles with lymphoplasmacytic aggregates at the periphery of the septa and the lobules. And eventually this thick sclerotic collagen will replace the fat. And if you get it kind of early, you can actually not only see lymphocytes, but you can also get eosinophils in here. So these are some examples of scleroderma that if you biopsied it, show evidence of the panniculitis. And so here you see the upper dermis is not really even involved yet. And the main changes are down in the subcutaneous fat here, markedly thickened sclerotic collagen in the septa. So the earliest changes of morphia, somebody comes in clinically and they're just barely getting it, they will complain that their skin feels like it's just a little bit tight and it's not really moving over the underlying structures as well as it used to. And they may not actually have any sclerosis that you can detect clinically. Just the skin just loses its mobility because you get this thickened sclerotic collagen that doesn't allow it to kind of move as easily as it should overlying the underlying fascia and underlying structures. So this is an example of scleroderma panniculitis. This is one that's a little bit earlier, still in an inflammatory stage. And if you get scleroderma panniculitis super early, really, really early, you'll see mostly edema of the septa of the collagen, be thickened with edematous, kind of a puffy myxoid kind of appearance. That's what you see before even you get much inflammation or you get the sclerosis. But here you get a lot of lymphocytes and plasma cells. So anytime you get sclerosis in the skin, no matter what the disease is, it can be accompanied by plasma cells. So it doesn't mean that they have syphilis or any kind of a spirochetal disorder. It's very common to get plasma cells whenever there's dermal sclerosis. Eosinophilic fasciitis, again, we showed nephrogenic systemic sclerosis recently, and this kind of shows that same sort of thickened amoeboid kind of pattern, and that's usually due to the thick sclerotic abnormal fascia that's kind of tethering and pulling the skin down. So again, this skin might not feel too sclerotic, but it's going to really not be able to be moved over the skin, and with time it actually does feel pretty thickened and sclerotic. And here you see again, notice that the dermis is relatively spared. The main changes are down in the lower portion here. You're dealing with the septa thickened here, but the main changes are down beneath the fat, and these are the septa now that are involved here. So you have to get a very deep incisional biopsy to make this diagnosis. And even though we call it eosinophilic fasciitis, They may not have that many eosinophils in the actual tissue. It's more of a circulating eosinophilia. And usually, I'd say in most cases that I've seen, you do actually get some eosinophils in here as well, but you don't have to see a lot of them to make the diagnosis. So again, it's often seen in association with the circulating eosinophils, although it is often present in the actual thickened septa as well. Now, Necrobiosis Lipoidica, we don't generally tend to think of this as being a panniculitis, but it can involve the subcutis. And once again, just like with any other sclerosing process, you can get a lymphoplasmacytic infiltrate. So these are some examples of the clinical of Necrobiosis Lipoidica. I think somebody's unmuted here. Let me just kind of mute everybody. There we go. Okay. And so again, these are the yellowish plaques with the, you kind of see through the epidermis. The epidermis is really thin. We talked about epidermal atrophy, but it's really kind of hard to appreciate that. But here you can actually see that it's thin. You can look right into the granulomatous infiltrate, that yellowish color in the dermis. And here's the diffuse layer cake inflammation, if you will, the inflammation involving all the way from the top to the bottom and side to side. It's palisaded granulomatous dermatitis. Here's some fat, and here you see that the septa has really has gotten so thick with this granulomatous inflammation with sclerosis, it's pretty much replaced most of the fat. So sort of analogous to morphia, that when it really gets markedly thickened, it'll replace the fat. Well, Necrobiosis Lipoidica will do the same thing. And here you see the degenerated collagen, the palisaded granulomatous inflammation surrounding that collagen, and then lymphocytes and plasma cells in the infiltrate. So very classic example of Necrobiosis Lipoidica. Now, the next pattern is where you get septal panniculitis with vasculitis, and this is localized septal panniculitis, so not lobular, so mostly septal with vasculitis. And we talked about this last week. We talked about vasculitis, and here, basically, the inflammation just likes to pick out the relatively large blood vessels and leaves the lobules alone, which has always been kind of curious to me as to why it does that, because you would think that if it's really getting these larger blood vessels, it would lead to some ischemia, and then it would sort of damage the fat, and then you get some inflammation in the fat. But for some reason, it doesn't tend to do that here, probably because I guess it doesn't spread to the smaller blood vessels. But the two main forms, like we sort of talked about last week, were Polyarteritis Nodosa, which is a pan-arteritis. It can involve anywhere from small to medium-sized blood vessels up in the dermis to the larger medium-sized blood vessels down in the septa and the subcutaneous fat, and give you like a small vessel leukocytoclastic vasculitis. And again, that is seen more commonly with the systemic form of the disease than the large blood vessel type that we see in the skin is. It's sort of the opposite of what you might think. And it can be relatively focal and subtle. And unless you really sample this blood vessel, you will miss the diagnosis. So once again, if you take a punch biopsy, there's a good chance that you're going to get some inflammation and maybe some periseptal inflammation, but you may not actually get the blood vessel. So if you're going to biopsy this by punch technique, you probably should do a 6mm punch, and you need to really go deep. You know, you can't just go into the dermis. You've got to go all the way down to the white plastic. You got to really push it down really far. And then you've got to really cut in there beneath the fat and make sure you get some fat that comes out of there as well, because if you just pull it up, you may only get some dermis again. So again, that's Polyarteritis Nodosa. It can give you a lot of different clinical manifestations. Sometimes it's just these lesions that sort of, you can feel them more than you can see them clinically. This has got a little bit overlying lipido-reticularis-like morphology. Sometimes they can ulcerate, like you see here. And here's the biopsy of one of these, a beautiful example of where it likes to pick out the blood vessel and leave everything else alone. So notice the lobules here really not affected that much. There's a little bit of perivascular inflammation involved in the lobule, but it's not really getting massive amount of lobular inflammation and fat degeneration like you see with erythema induratum that we'll talk about in a minute. So this is PAN, and this is a little small, probably small artery. It's not a large blood vessel. It's larger than a capillary or an arteriole or venule, but it's not really a huge, large blood vessel like you could see, say, with an internal artery, for example. But it is round. It does have a muscular wall to it. And then you can see the fibrin in the lumen here and some fibrin in the wall of the blood vessel here. So, and some inflammation surrounding it. This isn't secondary inflammation. This is really targeting the blood vessel, and it's just interesting that it doesn't really give you a lot of lobular involvement. Here you can see there's an elastic lamina in this case. Now, superficial thrombophlebitis, we also talked about this last week. Basically, these often give you kind of a cord-like thickening along the course of a vein. It tends to be migratory. It's often associated with underlying diseases. So if somebody gets this, basically you need to make sure they don't have an underlying cancer, they don't have some hypercoagulability going on. Probably the most common is somebody just has chronic venous insufficiency. Maybe they've been in the hospital or something like that, and their blood vessel clots. So again, you may not actually be able to appreciate this just looking at it. You may have to feel it, but here you can see these veins here that are inflamed, they're linear, and if you palpated these, you would feel this cord-like feel to them. So here, again, notice inflammation is mostly hitting the blood vessel. This is a little bit larger blood vessel, and again, it can be difficult to tell the difference between this and the actual artery, just looking at it under the microscope. Again, on a board examination, I don't really think that would be a fair question to ask you. But again, you should know that these two diseases target the blood vessels and tend to leave the fat alone. Okay, so this is superficial migratory thrombophlebitis. Now, there are some other forms of lobular panniculitis now, moving away from the septum, moving into the lobules, that can affect the fat lobules that do not have vasculitis. And this is a list of these, and we'll go through these right now also. And probably, we don't see this very commonly, but sarcoidosis can sometimes give you lots of fat involvement without really a lot of overlying skin involvement. You all should know pretty much everything there is to know about sarcoidosis from the standpoint of clinical manifestations to the way these things look under the microscope. So they're going to probably ask you some questions about sarcoids. You should be prepared for that. These are some examples of some deeper manifestations of sarcoid involving the skin. So these were actually patients that had the deep sarcoidosis. And notice here that there's nothing involving the dermis here, and all of these sarcoidal granulomas are involving the subcutaneous fat, and mostly the lobules of the subcutaneous fat. So this is a form of lobular panniculitis with granulomatous inflammation, and these are all sarcoidal granulomas with limited amounts of lymphocytic infiltrate. So differential diagnosis here might include another sarcoidal granulomatous process related, say, to a foreign body, like a metal like beryllium or zirconium. But when you get this massive amount of sarcoid involving the subcutaneous fat like this, it's pretty classic. This would probably be considered the Derrier-Rousset type. It might fit with that clinical appearance, but from a histologic appearance, we would really just say this is sarcoidal panniculitis and would favor true sarcoidosis here. Other things they can give you: sarcoidal granulomas, just make sure you know the differential diagnosis. Melkerson-Rosenthal, Crohn's disease, certain infections can do it, and then granulomatous rosacea can do it, but it wouldn't give you this dense sarcoidal pattern in the subcutaneous fat. Pancreatic panniculitis, often painful. Subcutaneous nodules can be anywhere on the body, but they tend to involve the thighs, the buttocks, lower trunk. They will often ulcerate, and they will extrude this oily or chalky white material. And these people will have some abnormality going on in their pancreas when you biopsy this under the microscope. And sometimes they don't really have a lot of pancreatic disease clinically. We had a case a few years ago where we saw pancreatic panniculitis. They went back and worked up the patient. They just had a slight degree of amylase elevation, and they found no evidence of pancreatitis, but they did find that the patient had a slight, little tiny fistula between their gallbladder and their pancreas. They're getting a little mild amount of pancreatic disease that ultimately was able to be treated with surgery. So if you see this, it means that something is going on, and the lipase or the amylase and the tryptase are elevated and is causing degeneration of fat. So it's a sign that something has caused that elevation of those enzymes. And this is not really a primary inflammatory process. Basically what happens here is that the fat gets degenerated because of these enzymes, and then it becomes an inflammatory stimulus. So it turns into soap. It undergoes saponification. And then if you can imagine, if you injected soap in your skin, it would be pretty inflammatory. So that's what's happening here endogenously because of the abnormal enzymes that get circulated. Here you see a couple of examples, just so these painful, diffuse lesions on the lower leg. Clinically, you can think about it, but it's certainly not pathognomonic. It could be a lot of different things here. Here's one that actually did ulcerate. It's got a little eschar on the surface. And this is the classic histologic pattern of pancreatic panniculitis. Lobular mostly, and the inflammation that comes in is secondary. Main changes is the saponification of the fat. This is pathognomonic of this process. So you get these little ghost-like cells here. These are the residuum of all these lipocytes that have been damaged and coalesced to form these fat microcysts. They're calcified into where you get this kind of purplish discoloration that's due to calcification. So this is the chemical calcification. It's calcium oleate-like materials that form in the skin. So this is really basically, if you took a biopsy of soap, it sort of would be analogous to this. So this is basically saponification. And here you see one that's got lots of inflammation here. Usually the inflammation is mostly neutrophilic. It really causes an acute inflammatory reaction. So all of these are the residuum of the little ghost-like cells of the saponified fat. And then you see all of this neutrophilic influx here coming in secondarily. Alpha-1 antitrypsin deficiency panniculitis, it's sort of an analogous process, but it doesn't give you the saponification. And you get these tender nodules, trunks or extremities, and they may be precipitated by trauma. It can be an early presenting sign, usually around the age of 30-ish or so. These are usually patients that have the homozygous deficiency of the alpha-1 antitrypsin deficiency. Sometimes they can be in a patient that's got the heterozygous carrier in the less serious form, but most of the time in these patients, they usually have a pretty serious disease. They usually also have evidence of lung involvement, and ultimately these patients don't do well with this. They can get basically this extensive, horrible panniculitis where they get this massive amount of inflammation, lobular inflammation, a lot of neutrophils, and it's due to enzymatic digestion of the lipid with secondary inflammations, analogous to pancreatic panniculitis, but doesn't give you this saponification. If you get it really early, and this is relatively rare, you can see minimal inflammation with dissection of the fat lobules from the septal, which is kind of interesting. If you see that, it's really one of the few things in the world that can really do it. But it's almost like somebody took some scissors and just went in there and snipped away the fat. But then pretty soon thereafter, you get this inflammation that leads to these kind of changes where you get this massive degeneration of fat. Usually you get some ulceration, some drainage, and it's often associated with systemic involvement. So here you see kind of a later lesion where there's all this inflammation, just this diffuse lobular panniculitis with lots of neutrophils. And maybe here you might have a little bit of that evidence of that sort of dissection of the lobule from the septa. If you get an early lesion, you'll see that, but it's usually by the time we get a biopsy of this, it looks more like this, where it's just this diffuse septal involvement with neutrophils, and patients usually are pretty ill. So just think about this when you get a diffuse lobular panniculitis with polys. Okay, another one that's important, lupus profundus. Okay, this is one that you'll probably, board exam will ask you about. Chronic recurrent panniculitis. This is the most common panniculitis of the upper part of the body. So this doesn't tend, it can involve the legs and the lower extremities. If it does, it likes the thighs more than the calves and the pretibial area, but it also likes the arms and the face. So just remember that this is the most common panniculitis of the upper part of the body. It's about 1 to 3% of patients that have lupus have this. It's often associated with some form of systemic disease. So this is less commonly seen in patients that have just pure chronic discoid LE. They'll give you these subcutaneous nodules. They're often painful. And when they resolve, they give you this very dense, woody induration, very, very dense, thick, woody feel to it. If you look under the microscope, you'll often see some evidence of overlying discoid lupus-like changes with some interface change, with some thinning in the epidermis, then usually often a superficial deep lymphocytic infiltrate. But the main change in the subcutaneous fibers is mostly lobular infiltrate with plasma cells, lymphocytes and plasma cells, and this diffuse subcutaneous hyaline lobular change. So it's very classic. The differential diagnosis can sometimes look like subcutaneous panniculitis, like T-cell lymphoma. We'll talk about that in a minute. But these are some examples of LE profundus. So you see the marked atrophy here, but if you actually reach over and feel this, it doesn't feel atrophic like a kneaded derma. This feels like a block of wood. It's extremely firm to palpation. And sometimes it involves a scalp. I'd say most of the cases I've seen usually are on the arms, thighs, sometimes on the back. And here you see a biopsy of LE profundus. You'll often again see changes of overlying lupus. So you got the lymphocytic infiltrate here, and then the diffuse lobular, mostly panniculitis that's thickened and it's basically replacing the fat here. So this isn't just septal thickening, this is replacement of the entire lobules here with this thick hyalinized sclerotic collagen and sclerotic fat here. And then there's the lymphocytic and lymphoplasmacytic infiltrate. So this is that mummified fibrin-like sclerotic fat here. This is pretty much pathognomonic for LE profundus when you see this pattern here. So expect to see this somewhere on your board examination. This is probably going to show this. So and then notice this is distinct from the type of change that we see with membranous fat necrosis. You don't get this pink hyalinized sclerotic change in that process. We'll talk about that in a minute. And then if you look at the overlying epidermis, you've got this thinning in the epidermis, thick basal membrane zone, vacuolar alteration. So you've got changes of lupus in the overlying dermis and epidermis over the fat. Very common to see that. It's not just purely fat in many of the cases. Now, there's two types of lobular panniculitis where we get needle-like crystals. It's probably the same condition, just different degrees of severity. And so subcutaneous fat necrosis of the newborn and Scleroderma neonatorum. This is due to abnormal composition of the fat, or they have an increased amount of palmitic acid that then precipitates at the time of birth. So subcutaneous fat necrosis thought to be related more to trauma, and you get granulomatous inflammation with the lipid crystals and the histiocytes. It looks identical to kids that have been on relatively high dose steroids for one reason or another. Maybe they have rheumatoid arthritis or some other childhood disease that they're on steroids and for some reason they stop it quickly. This can lead to basically precipitation of these crystals within their lipocytes. So that can look the same as subcutaneous fat necrosis of the newborn. And then Scleroderma neonatorum, kids are born with these crystals in their lipocytes. It's probably really the same thing, in my opinion. It just one has more of it than the other, and one's associated with worse prognosis than the other. They both look similar. You'll get these sort of thick, indurated lesions, often on the subcutaneous, on the dorsal surface of the child, usually at the time of birth, and usually seen in the first couple of days. Again, can be associated with hypercalcemia. It's thought to be related in some cases to obstetric trauma. The mothers that use drugs like cocaine have been reported with this. If there's intrapartum calcium channel blockers, there have been a number of things associated with this that you should just know about. And these are indurated plaques. The hypercalcemia that can be seen can last up to 6 months of age, usually resolves. And again, I sort of tend to think of scleroderma as being a general, kind of a similar variant to this. So here you see another example of this. And if you look at this under the microscope, the changes are in the lobules of the fat, and you see these little crystals here. So this is palmitic acid that basically is precipitating within these lipocytes. And then just like with pancreatic panniculitis or alpha-1 antitrypsin deficiency, when you damage the lipocytes, it can develop secondary inflammation. So this is really primarily an abnormality of the chemistry of the fat, and then you get a secondary inflammatory reaction. This one's got a few histiocytes here and maybe one or two over here, but the main changes are these crystals. Just make sure you're aware of what that looks like under the microscope. Scleroderma neonatorum, it's more diffuse. Again, may be associated with underlying sepsis and other metabolic abnormalities. Looks pretty similar under the microscope. Again, you can see the crystals here, and then the secondary inflammation that comes in as a consequence of that abnormal fat that gets precipitated in the actual lipocytes. Now, another disease that we see quite commonly, sclerosing panniculitis, also known as hypodermitis sclerodermiformis, lipodermatosclerosis, seen in patients with venous insufficiency. Often they'll have evidence of stasis ulceration or stasis alteration, very commonly seen in obese individuals. They get an inverted champagne bottle appearance. You can get ulceration, you don't have to, and it can be associated with atrophy blanche. So stasis can be associated with a lot of things. You can get stasis-associated limbovasculitis. We talked about last week with the vasculitis lecture. You can get this condition. You can get stasis ulcers. You can get cellulitis, so stasis is not a good thing. It can cause a lot of venous insufficiency, cause a lot of other conditions other than just swelling in your lower legs. So again, most of these people are obese. They get bad stasis changes. You can get, sometimes you get overlying lipido-reticularis-like change, but you don't have to. Sometimes they can appear just as solitary papules or nodules. They don't have to be diffuse yet, especially if you get them kind of early on in the evolution of the process. So this guy's got some pretty bad stasis change here. This guy's got the inverted champagne bottle appearance with some stasis ulceration over here. Notice the medial part of the leg is involved here. And this is the classic inverted champagne bottle appearance. Maybe even, that may just be the picture, but I think there is some evidence of lividovasculitis here as well. And again, if you look at that under the microscope, it looks pretty much like an inverted champagne bottle. So if you biopsy this, if you look at the top of the biopsy, you're going to see stasis changes. And you're very commonly going to see maybe evidence of stasis-associated lividovasculitis. Here, there's some fibrin in the walls of these blood vessels. There's an increase in the number of these thick stasis-altered blood vessels here. And if you look at the fat, you see the classic membranous fat necrosis, the little wispy appearance to the fat here, the somewhat edematous, almost mucin-like deposits of the fat with these little small globules. These are little fat microcysts here with variable amounts of inflammation. So this is the classic membranous fat necrosis that you see with patients that have hyperdermitis, scleroderma or sclerosing panniculitis. There can be some secondary inflammation here. Again, this is probably similar to some of the other changes that we've talked about, where you get ischemia, the fat degenerates, you get secondary inflammation. So this isn't really a primary inflammatory process, it's really secondary inflammation that comes in because of the ischemia. Here's another example, beautiful example, this little wispy lipomembranous change of the fat here. And you can actually do special stains and highlight that. It's probably just due to the degenerated fat that's got some PAS positive glycogen-like material that gets deposited here, and it can be stained with PAS and the Sudan black if you want to do that, but you don't really need to do that. You can see it pretty classically when you see this histologic pattern with hematoxin in the stain section. There are two forms of panniculitis that are lymphomas. So this is important to know as well. This tends to involve the lobules primarily. This is the disease years ago that probably used to get called Weber-Christian disease. I don't think anybody's really using that term much anymore. And so there's really two forms of this subcutaneous panniculitis, like T-cell lymphoma. There's the alpha beta and the gamma delta type. And some people have even broken the alpha beta type out as not really being a lymphoma because it's a relatively benign process, often seen in children. The gamma delta type is the one that you really want to make sure that you diagnose, because that is an aggressive lesion associated with a poor prognosis, often with a hemophagocytic syndrome. And both of these will give you a lobular, mostly panniculitis involving the trunk, legs, and forearms, often in older individuals, especially the gamma delta type. That can also ulcerate, can be associated with epitropism, and we'll show you some examples of that here in a second histologically. You can get this fat rimming. These lymphocytes are targeting the actual lipocytes. They actually are homing to these areas. And you get karyorrhexis, you get lipophagia, you get cytophagocytosis, and then you can get a lot of overlying epidermal necrosis. So the gamma delta type, this is not a good disease. These patients often will have these eroding tumors on the lower extremities. They get fever, they get hepatosplenomegaly, they get weight loss, pancytopenia because they get that hemophagocytic syndrome. And here you see some other examples. They can ulcerate. So again, if you get this diagnosis, you really want to jump on this right away. These patients have a very poor prognosis. They need to be getting in the hands of a hematologist or oncologist as soon as possible and get appropriate therapy. So again, this high magnification view, I'll show you a low magnification in a minute, but notice that you get all these cells that are just homing to the lipocytes here, and they break down. These are lymphocytes. They tend to break down, and you get these cells and engulf these cells. You get these beanbag cells. And if you do staining on this, they're positive for T cells, often positive for CD56. These are signs of inflammation. The TIA1, granzyme B, perforin, all these markers here are signs of inflammation. They're usually negative for CD4 and CD8 most of the time, and they're negative for CD30. Epstein-Barr virus is negative here. So again, this is a lobular panniculitis with lymphocytes and breakdown products of the lymphocytes. You get these beanbag-like cells. Notice the atypicality of these cells. So you should recognize, here's one of these beanbag-like cells here. And these cells are those of a lymphoma. So these are very atypical lymphoma-like cells here in the subcutaneous fat. So T-cell lymphoma can give you epidermotropism in mycosis fungoides, but can also give you a panniculitis. So just remember that there are two different patterns of T-cell lymphomas that you can see histologically. Now this type, the alpha beta type, can be seen in two settings, in children, but also in adults. Female tend to be more common. The hemophagocytic syndrome is less common here. This has a much better prognosis than the gamma delta type. It has a different pattern. I don't think that you're going to be asked to know a lot about this, but this tends to be CD8 positive as opposed to the gamma delta type, which is more CD56 positive. So it's not associated with CD8. It does express some of those cytotoxic proteins as before, but still has a much better prognosis. This will have a monoclonal T-cell gene rearrangement for gamma T-cell gene rearrangement. It doesn't have Epstein-Barr virus. And this can sometimes look like LE profundus, especially in the childhood form. So here you see a low magnification view. Notice that the involvement here is almost purely down to the subcutaneous fat. Looks pretty similar. Basically targeting, homing to the individual lipocytes. You get these beanbag-like cells, and these cells are atypical also. And so that's why people thought, again, it's like a lymphoma, but the markers are different here. So again, it looks the same under the microscope. It's got a different profile with immunoperoxidase staining, and patients tend to do much better with this disease than they do with the gamma delta type. This is a CD8 positive marker. Notice all these CD8 cells are just homing to these lipocytes, which is very interesting here, and has a much better prognosis than the other form. Positive or granzyme and TIA1. Okay, lobular panniculitis with vasculitis. There's really two main forms here, and we'll talk about. The most common is nodular vasculitis. We talked a little bit about this when we talked about vasculitis last week. So again, this is generally synonymous with erythema induratum. And again, there's two different types. There's the Whitfield and the Bazan type. I don't really think you need to know a lot about that. The classic form was associated with TB. The Bazan type used to be thought to be a so-called tuberculin, and you could actually find mycobacterial antigen in this. So if you get this type, you need to work the patient up and make sure that they don't have TB. I would do that anyway, no matter what it looks like under the microscope. But the Whitfield type is supposedly more commonly associated with hepatitis. And this usually is seen on the back of the calves, not the front of the calves, like Erythema Nodosum. Again, you get a medium-sized blood vessel here with lots of inflammation of the fat here, as opposed to Polyarteritis Nodosa or migratory Thrombophlebitis. So the back of the calves more commonly here. These often ulcerate. They'll extrude an oily material because the fat here is becoming degenerated. So here, inflammation in the lobule and the septa, and vasculitis with septal and lobular panniculitis. So lots of lobular inflammation with the vasculitis in this condition. And if you need a pretty large biopsy to make sure you hit this. If you just do a punch, like a 4-millimeter punch, you may just get the inflammation of the fat and you may not see the vasculitis. So all we can tell you in that situation is just lobular panniculitis. And if you don't see the vasculitis associated with it, we can't really make a definitive diagnosis because you have to have evidence of the vasculitis plus the lobular panniculitis to make the diagnosis. The inflammation of the lobule is granulomatous. It looks pretty similar to the inflammation you see with Erythema Nodosum that's involving mostly the septa. So here you get a lot of this lobular inflammation with granulomatous pattern. So it's suppurative granulomatous. And the differential diagnosis is an infectious panniculitis when you see this. So if we saw something like this, unless it had the really classic vasculitis associated with it, we probably anyway would still go ahead and work it up for an infection, but it does give you the suppurative granulomatous inflammation in the lobules with the vasculitis. And if you do stains for microorganisms in cultures, it's going to be negative in the vast majority of these cases. Calciphylaxis, we talked about this also. And again, this is a vasculitis. It's more of a vasculopathy associated with renal failure, but you get small vessel thrombosis of blood vessels with calcification here. So it is a lobular panniculitis because the fat gets involved. You get secondary fat degeneration, then you get overlying ischemia with ulceration and eschar formation. You may or may not get much inflammation here. It's just mainly the small blood vessels are all thrombosed because of the calcification and also because of protein S, protein C deficiency. And these patients very commonly have renal failure. They don't all have to have renal failure, but the vast majority of them do. So again, these are the kind of clinical manifestations that you can see with this. Notice that retiform purpura here due to the overlying necrosis and ischemia that's developing. Another example of that over here, and then these ulcers here. These often get secondarily infected, they get septic, and it's just one thing leads to another, and they often end up dying from this. So here, everything above this is just necrotic, degenerated collagen, eschar. It's sort of analogous to a burn. But all of this calcification, subcutaneous fat here, calcification, these larger blood vessels over here, and then with a higher magnification, even the blood vessels that aren't calcified are thrombosed here. So this is a lobular panniculitis without much inflammation, but it's basically dying because of the ischemic necrosis that's occurring secondary to, in this case, all of these small blood vessels that are thrombosed with or without calcification. So sometimes if you get an early lesion of this, you'll just see these blood vessels here that are thrombosed without much calcification. Sometimes the calcification is really subtle. So you may need to take more than one biopsy, especially if you're getting an early lesion. If you get a late lesion like this, it's obviously pretty simple to diagnose, but it's when you get an early release it's going to be more challenging. So the last few examples will show some mixed patterns, septal and lobular. So when you see this, you sort of think of things that don't fit the classic manifestations, things like trauma, factitial, infectious panniculitis, deep fungal, sometimes bites. So necrotizing fasciitis, it also can involve the fat. And basically this, when you get necrotizing fasciitis, can really involve all the skin. It can involve the dermis, the subcutaneous fat, fascia. This is really not a good situation. It's due to strep, staph, sometimes weird infections, Clostridium, Enterobacter. They can be mixed infections. Even things like Vibrio that we see in patients that get these summertime, they'll go down swimming in the ocean and they get these marine Vibrio down in the Gulf of Mexico, can develop a necrotizing fasciitis problem here. They get this redness, pain, and the pain is often disproportionate to what you see clinically. It may just be kind of reddish and somewhat edematous, but the patients just really complain of extreme pain. And then later on, the skin actually becomes anesthetic when it wipes out the nerves. And this can often be seen following surgery. You can get it in the scrotal area, the genital area, Fournier's gangrene. If it's down following surgery on the leg, we call it Molini's gangrene. If you look under the microscope, it's basically just diffuse inflammatory involvement of everything. So these are some examples. You've got this person's got gangrene going on here. These are all blisters that have occurred secondary to the underlying degeneration of the fat, the blood vessels, and secondary blister formation here. And this patient just had this lividoid pattern that was diffuse. And this is a biopsy. And again, it doesn't show it doesn't tend to involve the septum predominantly or the lobules involved, it just involves everything. So when you see something like this, it doesn't fit with one of our classic inflammatory panniculitis, you want to think about infection. And basically you want to culture this. This is really an emergency. So these need to be, surgery needs to be called in here. They need to get surgery off and they go in and just fillet the area open so that the ischemia doesn't get out deep and then cause gangrene, they lose limbs. So here you get this diffuse septal inflammation and the blood vessel was involved as well. Just this is secondary vascular inflammation just because of all the inflammation. So this isn't targeting the blood vessel, it's just kind of hitting it because it's wiping out everything in its path. Some other kinds of infections that you can see, this would be more like with a fungal involvement, say sporo or crypto or aspergillus, that can be involved there. Again, you'll sometimes see panniculitis without much inflammation in some of the zygomycotic infections, which is interesting. So patients are neutropenic, they get zygomycosis like fusarium, or they can get alternaria or things like that. They get into the fat without much overlying inflammation at all. They can give you subcutaneous nodules, plaques, they can ulcerate. So again, here you just get mostly inflammation in the fat without a lot of inflammation, and then here you can see the actual fungal organisms growing just in the septa here with this relatively minimal inflammation. So again, that can be seen in patients that are immunocompromised. So they get lots of fat degeneration, and you'll often actually see the organisms growing almost like a petri dish-like situation in the subcutaneous fat. So again, you want to get on these patients pretty quickly as well because they're usually immunocompromised. You can get granulomatous involvement with mycobacterial infections, with leprosy, with syphilis. So again, you can get, those can give you a panniculitis. Here's another example. Again, this one does have more of a granulomatous inflammation, but notice that's not really picking out the septa or the lobules specifically. It's just kind of a diffuse inflammatory process can involve just about anything. So special stains helpful here. Hopefully you'd see organisms. In this case, it's had lots of atypical mycobacterial infections, so just kind of a diffuse granulomatous panniculitis, in this case due to AFB. This was an example of a patient that had a zygomycotic infection, and notice there's relatively, there's no inflammation up here in the dermis really, it's all in the subcutaneous fat, and the blood vessel here is chock full of these organisms that are causing thrombosis. There's all this inflammation in the lobules, and then this special PAS stain, you can see all of these hyphal elements here with a relatively sparse amount of inflammation due to a zygomycotic infection. I think this patient had mucor. In this case, it was growing in the fat. So mucor, Absidia, rhizopus can get into the subcutaneous fat to get these diffuse non-septate hyphae involving the fat diffusely in that situation. And then physical agents, traumatic panniculitis, cold panniculitis, factitial panniculitis. These are things that can give you a sort of non-specific lobular and septal panniculitis without vasculitis. Cold, infants, people that wear tight-fitting clothing, non-insulated clothing, go outside, they can get these subcutaneous nodules. Classically, popsicle panniculitis, kiddos that are holding these ice cubes or sucking popsicles. Equestrian panniculitis, especially women, they go out they ride horses when it's cold outside. They can get a panniculitis on their legs. And then sometimes you get scrotal fat necrosis in prepubertal males. When we look under the microscope, it's usually mostly a lobular panniculitis without vasculitis, with necrosis of the adipocytes. And then again, sort of like with some of the chemical panniculitis, here you get the necrosis and the secondary inflammation. So this kiddo was sucking on a popsicle and got panniculitis here. This was the equestrian panniculitis. This little kid had been out, his hands got cold and got panniculitis secondary to that. So notice here it's mostly a lobular panniculitis, often with lymphocytes, but sometimes with some neutrophils and without really any definitive vasculitis. So that's what happens when your skin gets really cold, gets damaged and gets secondary inflammation. And then people like to inject things in their skin, unfortunately. People like to inject silicone to make their buttocks bigger. Breast implants rupture, they get secondary chemical panniculitis. People inject a lot of other things into their skin. Sometimes they inject milk, they inject vitamins, and all sorts of things get injected into the fat. And once again, this is a diffuse, non-specific inflammatory reaction. There's often neutrophils, there's granulomatous inflammation. You can polarize it. You'll see evidence of polarizable foreign material. In silicone, you get the little tiny bubbles inside the histiocytes with silicone. That's pretty characteristic. This person had breast implants ruptured, had to get them excised. These guys were injecting their skin with things, trying to give cosmetic changes. And we were seeing people that were getting these hyaluronic acid injections. The mesotherapy can give you this kind of diffuse granulomatous separative panniculitis. It's relatively nonspecific. Here you can see calcification of the soft tissue. And this is an example of a paraphenoma, injected silicone and other materials in the skin. It's a lobular, mostly panniculitis with granulomatous inflammation. And if you look inside the histiocytes, you see these little vacuoles. Another example here, diffuse lobular granulomatous panniculitis. And all of these little tiny droplets are silicone droplets here. So this is silicone granuloma in the skin here. And this is pretty characteristic. So thinking if you get small little tiny bubbles inside histiocytes that are relatively similar sized, think of silicone. If you see crystals and things like that, it's more likely to be a paraphenoma where they've injected things that contain other materials other than the silicone. If they get inflammation with silicone, if they're injecting it for wrinkles, for example, that's supposed to be a surgical grade quality silicone, but sometimes people do get a secondary granulomatous inflammation. There may be microscopic amounts of impurities in there. And if you biopsy, it looks pretty similar to what I just showed you there. Traumatic fat necrosis, some people get like trauma from maybe a car wreck, or they get injured in some kind of other kinds of trauma. You can get like a diffuse warm erythematous process that then heals with scar and atrophy. Again, if you look inside the microscope, usually tends to give you relatively limited amount of inflammation. Some fat degeneration. These are fat microcysts, they're not actually lipocytes any longer. You may get a little bit of inflammation, but if you do, it's mostly lymphocytes, maybe a few neutrophils. And then this heals, usually with some atrophy because the fat gets degenerated. So it sometimes gives you a little bit of that membranous fat necrosis, similar to what you see with lipodermatosclerosis. Here's an example of one of these where they did get some inflammation and ultimately this healed up. This is all due to trauma. So here we got some inflammation, granulomatous inflammation heals, end up leaving you with some atrophy. So most of these are relatively straightforward. I think if you get biopsies on the board examination, you get some pretty classic examples, some good examples, say, of Erythema Nodosum, maybe nodular vasculitis. You might see something like Scleroderma Panniculitis, might see an infectious panniculitis. So if you just remember this algorithmic approach, septal mostly, lobular mostly, with or without vasculitis, and the type of inflammation that you see, you can really work through this pretty well and make a pretty good differential diagnosis, come up with a pretty specific diagnosis in the context of clinical information. So hopefully you guys enjoyed that. You and the question.